Change it.
Which one of those? Almond isn't. Basil. We need to worry about basil.
This tissue's been bothering me. I'm going to get rid of it and wash my hands. I'll be back.
It's been sitting here for a while, that's reasonable. We'll just not find it. So we'll just go. Oh, wow. I have to come in, okay. So if there's no one there, then you don't worry.
Yeah. Yeah, but there is one person.
Yeah.
So we'll just wait.
We're putting the lights on in the other part of the room. The lights on to make it screen.
Hey,
No, we've got this.
no, we do have pieces of paper, so you don't need a device. So it depends on how many other people have devices. Because you can do it either way.
I haven't got devices purely because if there's no one in Switzerland. If there's no one in Switzerland, we don't need devices.
I'm happy with whatever's using. That's consensus.
Yeah, and it doesn't matter if there are some people online.
We'll just make it that work.
Yeah.
If there really are then.
Well, no, well, they are there because they weren't there when I logged in at 4 o'clock and they are now.
Okay.
So they are really there.
Well, I guess we should get going. Or should we just check what we should about? Whether it's likely to be a problem with Switzerland or we'll just keep going.
And then there was somebody else that was going to join us.
So I encourage you to sit with Leanne because we are doing group work and it will be very hard. We're going to do some group work and be very hard to do group work at a different table. So I suggest sit with Leanne.
You want me to hear?
Yeah.
Would you like me to sit there?
Yes.
What's in the swimming?
We're the pretty mask and shower this month.
Well, I was looking at lights and thinking you might need some light.
What time is that?
So let's start now. If you were going to do something that will. But I should open the PowerPoint.
Don't want to go and remove the cake from the.
Bring one, bring it in. Okay, let me quick- It's your preference.
For dental and medical and health, medical sciences now, or something like that. It's a school, but faculty of science.
I can't go. Oh,
So is that sharing screen?
it's fine. No. It's good. I'll show the screen because it's easy. Mhm. Doesn't look like we've got anyone from Basil. Just- Should be all right then? Okay. So welcome to our presentation or workshop this afternoon. We'll be looking at ways to assess cases and use of cases in educational purposes. So I'm Joyce Spark, I'm the pharmacy lead at University of New England, and with me is Greg Maynard, who is pharmacy lead at CSU at the moment. And this study started, as Deborah pointed out to me, once I came in a long time ago with a case in a workshop in Adelaide with that Eva ran in the days when she was running workshops for pharmacy academics. And I was fascinated by the concept of the sort of difficulty around writing cases, and which came from a paper that she presented at that stage. We have a consortium of people across the country who've been sort of playing in this space for a number of years. So today we want to introduce, talk about why we use case studies, and then the possible applications of the healthcare difficulty cube. The learning outcomes were understand the difference between case studies and cases, used and provide some context, actually use the health case difficulty cube to assess the difficulty of a case study, and reflect on how case difficulty might be used to scaffold case studies for learners at different levels of understanding. When we use cases in education, we can use them often as written in assessment in both written and oral forms. And oral forms tend to be where we might have multiple cases, and I think it's important that if you've got multiple cases, that they're equivalent levels, so there's not some level of difficulty that means that one group's going to get a lower mark because of the case rather than because of their ability, because it's harder for them. And there was one case someone talked about where they had a couple of cases. One, there was the students could do a fatal error, and one they couldn't. So the students in the group that could do a fatal error, a number of them failed, whereas the other case, they didn't have the fails because they didn't have that. There was that different level of difficulty associated with it. And we don't always think about that when we're preparing cases. And we can also use them for classroom learning activities. and outside of class learning opportunities for students. So it's a whole range of different reasons that we might use cases in educational purposes. If the case is actually there to provide context, and well, they do provide context in any situation, and to identify what the student knows. And then that sort of tends to be cases, but what case study tends to be more where you're wanting the case information where students have to apply knowledge to a particular case. So sometimes they're just used to provide context. Sometimes the students have to respond in a particular way because of the particular person that's in the case. And that's the two ways we tend to use cases in an educational context. And we tend to be thinking about case studies as where the response required is to need to use the information about the patient or the situation to actually respond to the question rather than it just being there to provide context for something else that you're asking them to do. And often they're used for students to show what they can do rather than what they know in a case study. Oh, yes, that's what I'm talking about. Reliant on particular information and application of knowledge to the case when they're answering the question. So case difficulty cube, this is where we've got three axes. We've got the analytical axis, the conceptual axis, and the presentation axis. And we still think it's a cube, but it's actually that means that if you want to only increase one at a time rather than all of them, because it's the volume that's important rather than the sum of the bits. We're still working on that. Actually.
All right. So what we were looking at, so we've introduced an idea of the three axes, and the three axes can be broken down into, we can give them a numerical value. And so as the difficulty increases along a particular axis, you give it more marks. So at the analytical axis, we're still kind of deciding on how to do this one. And it depends on what type of case study you're actually working with or the format of the case study. If you're doing an oral case study, probably the 1, 2, 3, 4 kind of works. If you're looking at a written case study, then using the Bloom's taxonomy for numbering system is probably the better option. And so we're still trying to work out whether you need two completely different cubes for a written versus oral, or whether this is a sufficient overlap where you can combine the two. So if we have a look at that first point there, summarize pertinent information or respond to a simple question that only requires recall. So the first point is that's a simple case. They don't really have to do too much to respond to the case to get it kind of working. The second level of difficulty is students need to make or identify a recommendation. So the case gives them a prompt, they need to respond to it, and the outcome is easy to get to. So there could be a protocol or a guideline that they can literally just go, here's the protocol guideline and follow it, kind of verbatim. Step 3 is students need to make and justify recommendations. So not only do we need to know that yes, they can get the right answer, but they need to know that they know how they got that right answer. And so there's that extra level that they need to do. The other thing is that to make it a little bit easier, we've said that it doesn't impact on other parts of the case, or the other parts of the case don't really impact it too much. So, for example, first line therapy is going to work. When we start looking at number 4, we need to start considering the other cases because they're going to start interacting. So pseudoephedrine and hypertension, or diabetes and Watts, or something like that. They actually have to start thinking that first line therapy is not going to work in this situation. So I'm going to have to make some different decisions. And if I make a decision, can it actually start influencing what else is going on in that patient? And so there were our 4 levels on the analytical. On the Bloom's taxonomy, we'll just put the remember and explain kind of like at the beginning, then application will apply as the active verb in a kind of question, analyze and evaluate and adapt and create for the 4th level of analytical.
Can I just make sure I put my head around this? So say it might be, John has hypertension.
Yeah.
So a type 1 would be, what are full drugs that we use to treat hypertension?
Mhm.
Type 2 would be, what drug would you recommend as first line agent? for
Yep.
John?
Yep.
Step 3 would be, what would you recommend for John and why?
Yes,
And step 4 of type 4 would be, John also has gout and impaired glucose tolerance, and what drug would you recommend for him? and why?
so that fourth case is multiple comorbidities that are starting to interact. Exactly. So the first point, you're right, it's kind of like what is used for hypertension. So sometimes you can flip that around and say, this person's been given this drug. Can it be used? What's it been used for? Or something like that. So it's just really straight recall knowledge kind of level. Yeah, good.
But not so much that he's an elite athlete and kind of fetish, and that he's going to be prescribed that to lose his gold medal.
Absolutely. So
That's a type 4.
that's type 4. Oh, I don't know. Yeah, maybe a type 3.
Yeah.
So yeah, where other parts of the case start to interact. All right, so the next part was the conceptual, no, spot on. Conceptual axis was, again, so it's a 3-point kind of scale, one simple concept. The person has hypertension or the person has conjunctivitis, they have a rhinitis or something like that, fairly simple. Then you get the multiple simple concepts kind of being combined. So the person has conjunctivitis and rhinitis, or they've got hypertension and conjunctivitis. So you're starting to combine a few different things, or you could go for something a little bit more rare, maybe a skin condition that's kind of more unusual in its presentation. Or if you're looking at prescribing and scripts that might be coming in, you're looking at a baclofen script, or a amantadine for Parkinson's disease. So you're kind of going, yeah, that doesn't happen very frequently. So it becomes a rare concept where the students might have seen it, but they've really not had to deal with it or work with it in great detail.
That's when they go, I don't know why you're asking the pharmacist about that, pharmacists don't know about that,
Exactly.
right?
And then the third level of conceptual is you've got lots of multiple simple concepts or more difficult concepts. So basically it's more a complex case with multiple comorbidities for that particular situation, for that particular case. And then the presentation is how is the information or the context and the information relevant to the case delivered. Now, if it's simple and it's just the case and it's all just done in a single paragraph kind of thing, then the case is required to provide some context to answering a question. And so it gets a mark because if we give it a 0, then it doesn't work. So this is just making the presentation axis work. Where it gets a little bit more complicated is if the case, and the way this one works is you start adding numbers and you can have multiple combinations of these. So the more you use, the more complex the presentation becomes. So one of the things that we felt made our case more complicated is if you didn't give any scaffolding. So if you just gave the case, there was no sub-questions, kind of like focus on the hypertension, have a look at the medication here, or have a look, are there any drug interactions, and kind of step them through the case. So if there's no scaffolding, we felt that was more difficult than a scaffolded case. Information elements are not grouped. So the information that you need to process the case are now being separated. So it could be that you've got a paragraph, a blurb about how the patient is feeling, so maybe some social context, then you've got vital signs somewhere else, you've got the medication history somewhere else, maybe you've got an x-ray. And so this kind of ties in, there's a little bit of crossover between the multiple information sources at the bottom, and the information elements are not grouped. So it depends on how they're being presented, will depend on which one of those is going to be pulled up. But you're starting to get complexity because the students now have to integrate knowledge from different parts to actually interpret the case and identify issues and make recommendations. Then onto the third one, you've got excessive information.
Sorry, Greg, just wanted to ask, how does that go for an oral case where perhaps it involves history taking and student has to ask the question? I'm sorry,
last sentence.
I guess, but does that element, sorry, I was just going to specifically ask, does that element apply? Because whether or not the information is grouped depends on the student's thought process.
Yeah.
As to whether they have a logical structured history taking approach, so they group their collection of information, or,
Yeah.
or does that one not?
But the actual presentation of the case doesn't.
Okay,
So the present case is relatively straightforward and simple. It's the fact they've got to extract the information that makes it hard. So that's the information's not there in front of them. They have to actually extract it. And if they don't ask the right questions, they don't get it.
okay.
Okay, yeah, so absolutely. So the last point there is where we think that the oral extraction of information creates the difficulty, and so that's just where we keep it. If you wanted to give extra information and say there was a medication history that needed to be extracted, and then you had medical history somewhere else, then yes, definitely, I think you could actually go to one of the other ones and add that extra level of complexity by using that second point as a marker.
Because the last
The-
probably comes into the oral as well. If they've got
Yes,
got a hearing impediment or there's something else, then there's an extra thing in the communication. Depending on the patient and what you tell the patient. Barriers.
so that was another kind of part of it. All right, so just jumping back here. That's right. Excessive information. So we've seen cases where you have like 2 pages of data that you have to scroll through for a 5-mark question or something like that. Is the amount of information you've given suitable for solving the case and the number of marks that are actually available? So consider how much information is being provided. The other thing that we put in that same kind of concept is extraneous information. How much of the information is actually relevant to actually solving the case, and how much is not necessary. So maybe you've given them blood pressure data, you've given them blood glucose and HbA1c, and you've given them FEV1 for their COPD or something like that. Now, the FEV1 is fine, the blood pressure is fine, the blood glucose is fine, but the HbA1c is not fine. You've got all this other extraneous data, which is okay, but they have to sift through it and work out which ones are okay and which ones aren't. And so that increases the complexity because you have to sift through and make a decision on, do I need to act on it or not? All right, and so that was that part. We've talked, so this part here, multi-part questions. So when you've got multi-part questions, and this often fits in with the scaffolding sometimes, where you've got that first question, if they get the first question wrong, does that impact on the amount of marks that are available for later on in that question? And so if the answer is yes, then that actually makes it more difficult, because they do have to get, even though it's scaffolded, they're going to lose marks because they made a mistake earlier on. And then we've talked about multiple information sources, talked about barriers, or kind of introduced barriers. So barriers to extracting information. So the information could be there, but if the patient is hard of hearing or they've got a visual impairment, and so they can't read, and so you have to provide information in different ways. And so there is an extra challenge to actually solving the case. So that's where we felt that the barriers kind of fitted in. It could also be a child that is running around in your case study and the person is pretending, or if there actually is an actual child in your case study that needs to be, well, the challenge is overcoming that barrier to communicating with the patient or the carer. All right. And we've already talked about extracting information. So this was a short answer, just taking it on to an example now. So a short written exam question. So we have a teenage girl with mild acne, comes into the pharmacy and asks for something to help her skin. She has not used anything previously. So we have a context, we have a patient, we have a condition, we have the severity of the condition, we have the context being in a pharmacy. Then we have some questions. So which of the 3 recommendations below would be the most appropriate? So there's only 1 mark being given out there. There are a couple of different things. The student can choose any one of those, but then they have to explain why. So now we have a scaffolded case. The analytical, the presentation of it, it's all in one place, so it should be fairly simple. So 1 point there. The concept itself, or the concept itself should be a 1. It's a fairly simple case. The analysis, probably a little bit more than a 1. It's not just a straight recall. You need to explain why. So it could be a 1 or it could be a 2 if they need to justify. So yeah, depending on how you interpret. So if it's explained why, then it's a level 1. If there's more of a justification required, then it might go 2 or 2. So it depends on how you sum those up. So if you're multiplying it, it would be a 1 times 1 times 1. If you're adding it up, then it ends up being a 3. So we're still tossing up whether it's a summative add up or if it's a volumetric area under the curve kind of thing.
Erring on the side of the volumetric at the moment.
Yeah,
So that would
and
be a
with-
simple case,
That would. so
or
this
or
would be-
1 by 1 by 2 or 1 by 1 by 3,
Yeah.
depending on what the analytical range.
Yeah.
This was.
Good. All right, did you want to do this one? So,
So this is moving, I guess, on to oral cases that are a bit more tricky. So this is a 5-minute oral assessment. Oops, that's right. I'm supposed to be using the microphone. 5-minute oral assessment. Patients entering into the pharmacy and asking questions, and the students expected to ask questions to identify the patient symptoms, the usual things we'd look at an OTC question. They've only got 5 minutes. The topic is one that they've studied, and the students' triage and communication skills are the focus of the assessment. So looking at the actual case. So Mrs. Jones comes to pharmacy and what she could do for a sore lip and what she could do to relieve it. And that's the information that's provided would have been provided to the sick patient or to the marker as far as what it is. So going back through the looking at the analytical stage, there's, I guess, fairly straightforward from the point of view of the analysis. But they do need to identify and make a recommendation. Because they've got to actually extract questions and make recommendations. So that would put it at a 2 for analysis. Then number of concepts. It's just content, so it's a single concept. And then the presentation access gets a bit trickier because you do need the case to answer the questions. There's no scaffolding, and the information has to be extracted other than that, I think. So that takes up to 3. So you can see how very quickly the presentation access can get quite tricky as soon as you start having to extract things or that sort of thing. So this becomes 2 by 1 by 3. So we're looking at about a 6. So oral presentation can become, unless you keep them really straightforward and simple, can become quite high in scores very quickly because this patient, because of the need to extract information. And if you don't ask the right questions, you're not going to extract the information to actually get the right answer for the question. So what we thought that we'd do for the activity was to break up into groups of 3 or 5. And I'm not sure, maybe we do online before, or was it a different one? So we've got access to Google Docs, but we've also got access to a hard copy for people who are in the room. That's paper. So what we were thinking is you choose, we chose 5 topics, sorry, 4 topics, a couple of OTC and a prescription. And what we'd like you to do is to get into pairs or groups of 3 and create a case that is for one of those topics, and then give it a score on the, think about how you think it would relate to the case in the cube, and then we'll circulate cases around and see what other people think of the cases, and then we'll try and look at how we can manage to change the difficulty of the case from a starting point. So starting, if they were topics we thought would be reasonably straightforward off the top of people's heads. So if you'd like to choose one of those topics, do you want to sit in groups and choose a topic with the person you read? It would be good if they were on different topics, that's all. And
Allocate.
allocate.
Yeah, tell us what to do with.
Has anyone got a preference for a topic? No, okay, OTC rhinitis.
I didn't want that.
Missed out. I did think tonsillitis. Prescription antibiotics and prescription hypertension.
All right, and the people online,
And this online issues.
yeah, you can choose whatever you like, so oh, we just lost Jonathan.
Joy.
Yes, so I'll hand up. That's different pieces of data.
I don't think there's good things, but.
Right. Okay, that's a big leap. How are they around?
Do we give it to them in the we've got. So. If you allocate that level of difficulty on, because I'm used to.
Sure.
How we. Prescription for.
Yep, perfect.
Sorry. Just go for the, yeah. This prescription, just say someone with a prescription, is it a female or a male? Does it sound how long it's do we don't know? Presents with a prescription form. So you say no. No, the sound. And they have it. Are they too? Why are they changing? Why is it being changed? An intervention would be, we need to stop. You need to expect the one that was the previous study and now the group. You need to stop that. So you need, as an examiner, and I'm not, so I'm sorry, I'm just. As an examiner, you just have to get that word, you've got to stop. Let's see intervention. Once is a concept. Very much.
And like, like, part of the initial question. The student. That is probably not
Is this a board? Yeah. So it. And is it processing? And sometimes, you know, so sometimes students answer the question, but they don't process the image. What are we doing about the information? And I guess that's the process. That's a high level. It's more. So are we trying to ascertain the level of difficulty without giving it marks? They're switching. They're not too doing the others, they want to do that. The communication switches from one issue to another. After you know that that's what they're doing. So they're making sure that they understand if they have it, so they not wants to repeat, and the doctor's changed it. Yeah, so that has to be ascertained. I guess the test is the history test. And that goes to if that's again, because sometimes I say, that's the same. Yes, we don't expect information.
Yeah, so what I was describing. Yeah, well. And we support this.
In my experience, the first person that answers is, has the doctor told you anything about this medicine? But even that way to replace it, it's not the answer to no. Exactly, and what is it? And it's still different. You said it's for hypertension. Or they've not touched on the core issue that we have to about whether it means. I think it requires a certain level of professional thinking or medical and that you might fix this.
My role with I like getting progress. The last council.
Why am I looking at
Yeah, so basically,
why do I need to
yeah,
give you how it should be simple? The analysis. You wanted one where they just were so and you. The importance is that you don't end up it's very much but it's linked to the don't really know how, but really who's role by bringing it on up. We can't, we shine which extract. Very so I was like, really must have been they're gonna.
In the end, I had a competition. It's not just oral was just done from top of it. The idea was sort of multiply. So I start with similar here. Yeah, well, some of these will. I'm not.
Usually, well, at the months of what it would be 10 minutes.
So there must be a huge
simple kind of thing.
So it's the top up, and once you put this. Yeah,
Could be partial, obviously, you know, like just.
a lot of these score and then do a series of without which exceptional. But
They don't get it.
it's scoring.
They're touched.
Right.
Some of them are just the on the scene.
Yeah.
But,
Yes.
My boys are requirements, so we're learning about. I'm very supervised. So we've got, school to pay, and we've got, very good abuse board. And we've got my. We can see.
either way, we have to follow the ticks that we have allocated. Yes.
So you
That's
know,
why I think we can admire where it's at.
One of the things that and the I was just trying to say.
They could start with one step, and then the next bit, the next speed is that you probably you can be and they can all separate when you don't need. That people will argue.
We've got.
People will argue. That accept that I think this is my really important. Because academics.
What we talked about. Very.
Only because I know what you're saying, understand. You can have one student.
For the patient doesn't bring the script.
Is to get them all at the same level, entry level.
What other approaches are you aware of?
I'm of the view that we
Comparison
really well
organisations across.
at the pharmacist board level. Now it's, almost, parrot level.
I'd like to find somebody that's on. Around.
And taking away things that
And it's very limited, so why that's.
just with
That's the
one scenario that you see. Then there's another difficult, and the rest of it was just really good. Again, so, and three is the ones in the and you want to get and somebody if there's a cheat, questions and every needs the any questions.
But he was to pay them. I was getting the letter, and it's more a case of recall rather than application. It all is under decision. So that comes all right. Actually, gives us a thing in the letter.
So, what is
Well, but it wasn't just.
the other control?
In the car.
And you were talking about
Yeah,
assessment.
actually one thing's just. One thing to just. I like to put it just.
Yeah, no, it's that. You said at a level.
What we would say, yes, is that.
I would say they have to justify saying.
It's a multi-
Unless we stop. Unless the doctor says.
So that's what we. And also.
They have to find it out. They're fine, saying. We've been having that higher order. Just for the reason. See, but just.
So.
And then.
Great, and then you think it's not.
Well,
And then
well,
you
the other, not one, this way, it's a great involved. I find it. I think. It's a question to, but that is the conference. I need to be. Yeah. That's just roughly around the track.
And that's. Meanings. That's really much. So there's no signal.
Well, there is.
There is.
So there's going to be, so.
It's the same, isn't it? It's still.
Yes, it's actually, so when I say.
And therefore we need to be able to do it. What we're looking for is that knowledge, attitude, some of what we're not necessarily.
Yeah.
That's why I'm talking about that.
Building on.
Yeah, and I'm already such a baby. Oh, that is. John, and he would have said, I was making a kind of and he doesn't want to push the building.
Yeah. He said, that's. Yeah, that's.
Yeah.
I'm enjoying the training about.
I just think I guess it's got some issues on all the songs.
I don't mind.
Yeah, it is.
Information on the.
Oh, yeah.
Well,
Yeah, so. And once it gets to the budget, it's not discussion. So.
Well, that's part this is terrible.
So this may have. That. Yes.
I'd say.
Everything.
So that's. That would be one way.
Yeah. And what the house valve was.
Yeah, so it's sad.
But when it comes to my simply being is the issue.
I know some. If you want to be, I That's. I'm just always right. I mean,
Okay. Oh. Stop, right.
No, never would do it. I will not do it. Not making my possibly in 7 in the morning. Been up an hour, 12 hours. Yeah. So they'll have to take this package. One single, yeah. But is it not, I can find that it's rhinitis and then treatment, so it's. So it's. Okay, and this presentation.
Yes, I just seen this picture, you know, just. And we should be well.
And then last question would be, what should
Right.
is the patient? Right, like, scaffolding is when we tell the more, I think, by agreement.
Yeah, so we've got a lot of context. In terms of, again, I said simple. Great knowledge.
It's not it's no changes.
Yeah.
So they did just.
I suppose get thinking of get wrong, there's some. But I can actually see how that could be. Sure. Speaking.
Okay, so what I'd like is for the people. Who. Leanne and John, would you just like to talk about how you saw the dry eyes one? Please.
Too late. Okay, how do we sort of dry eyes? We made a case because we haven't got a. Smith early 20 comes to the pharmacy during the break semester. He's wondering urgent medication for dry eyes, was provided up to screen time on his PlayStation. I received no treatment before, he didn't go to the doctor, he rocks his eyes and it's worse. This is an oral case. The expected response is the student identifies. That this is a minor ailment and the student can recommend any OTC eye drops for the patient. So we went with 2 because the students need to make a recommendation. It's a reasonably cut and dry eyes. You use something to treat the dry eyes. There's no obvious comorbidities or complications. We went with 1 because it's one simple concept, dry eyes. And we went with 2 because obviously you need to use the case to answer the question and you need as an oral case to extract the information from the patient. So we went 2, 1, 2. People who wrote the case, is that sort of similar to what? Have you written, what is that, have you, is that how does that relate to what you were thinking when you wrote it?
Yes. We just made it, I mean, we just made a simple case for this one, yeah.
So what was the total, sorry?
We went, was it total mark? 3, 1, 2. So do we multiply or do we add?
And the original was 2, 1, 3, so it's very similar. Right. And so that unstructured versus not, whether it's an unstructured case or a non-unstructured case, I suspect is the difference, is that right? So do you want to talk about, you were looking at the hypertension case, so do you want to talk about how you scored that?
So for hypertension case, the case is for oral exam, 5 minutes. So 50-year-old male enters pharmacy, presents prescription for irbesartan, 150 milligram per day. Student needs to interview with patient and determine that the patient is currently taking perindopril 10 milligram. Student needs to identify the patient has to stop perindopril and commence irbesartan. So I think we have different scoring here. So, but the first for analytical we score 3. We are all agreeing with 3, and then for conceptual 2, and then for the presentation 554. Yeah, is that correct?
But, no, I think this group also looked at that case, so how did you score them?
If you average it out, it's 2.5. So we went with 222 or 312. And I guess maybe just from context, when we're teaching students to address this type of case, we teach them a structured questioning technique. And so I guess the information is gathered in quite well, if they do it well, quite a logical way. And so it's reasonably, the approach is structured, even perhaps if the information is not written on the page, it's structured. So it's relatively simple, I guess, if they follow the structured approach that they're taught. So that's, I guess, where perhaps the lower scoring comes in our minds.
Presentation access is actually, I think, the most difficult. And talking to people who wrote that case, what did you think? What processes were you thinking around the difficulty of the case?
So our scores were 3, 2, 3. So if we just look at the presentation component, we ticked for no scaffolding. The information elements not grouped. And that is information required to answer the case missing or need to be extracted. So that's what we ticked.
That's not possible.
The first one, which is the case is interchanged the case. So that would make it 4.
Sorry, I think we should. Maybe. Okay, I'm sorry. We did say that one, yeah. We just skipped that.
If we did.
That would make sense.
Spectate, we need to have spectate.
Which brings you up very much in line with the first group of the system. But what was the level of difficulty that you thought the students would have trouble with? I think maybe what.
So I think in relation to your comment, Leanne, I think although yes, we do teach them that structured way of questioning, I think although they could answer the question, like ask the question and receive the information, we thought it's actually that processing of that information and the analysis that's required and what to do with that information.
And what was it that you thought was the for one of their descriptions, the students would say, you're just tricking me, but what was the complexity that was in that meant that it was a bit higher?
So I guess simply it could just be considered as a drug interaction possibly, or it could be a duplication of therapy, but also I suppose understanding the history that someone has previously taken an antihypertensive and the need for a change in therapy. And I suppose understanding if, I don't know, if a period of not taking medicine is necessary or making that sort of decision around that. And I suppose relaying that back to the patient as well.
I think the consistency that you're looking at.
Case, and where I'm having trouble in scoring is, I don't know the answers to the questions the student might ask. For example, does the student, the patient know the intention to change the therapy, or was that unknown? And it would depend upon the patient's answer, and you can add a high level of complexity by having the patient say, "Oh, I didn't know it was I was to stop the this."
There was a lot going on with it.
Yeah.
Which I guess which may not have been clear, but it was that need to stop medication and for them to actually remember to do that. But I was just.
I'm also thinking, whilst we're talking now, that we're looking for the competency of solid history taking and processing that. So it's also listening, active listening, these skills and competencies that we're along the way. I mean, you're scoring here to in a different way to what we usually say. We're just usually in the lingo of competency, skills, what level, entry level, professional level, you know, all of these play a role. And who we're examining. But I agree with John. I mean, if the answer goes either way, it's a different outcome.
So it's very hard to
Yes.
score a case unless you know what answers the patients are meant to give.
which is. Yeah, and while we were talking about this, I was thinking, one of the things that you could change the level of difficulty is whether this is a patient who's brought in a new script and they're a new patient to the pharmacy. Or, and I didn't think about that before, because that's when it becomes, if they've got this, if you provide their dispensing history, which says they're on whatever they're on. So that would change, would be a way of changing the difficulty of exactly the same case. One, you provide a dispensing history that says they've been on it. The other, you say they've just brought in a script and they've never been into your pharmacy before. So
Yes.
your level of questioning is a different thing, and that's one way of changing the difficulty of the case.
Just looking at the scoring system, that would potentially make it more complex.
Yeah.
Because then you've got multiple information sources.
Of course.
So I guess just coming back to the conversation that we're having before, perhaps the history taking aspect actually needs to be scored at more than one. Because perhaps inherently an oral assessment where you have to do an effective, take an effective history and synthesize that information is more difficult than something where all the information is already provided and you need to pick through and just find the right stuff. So maybe that is more than one, or we need a different scoring system for written versus oral from the presentation perspective, so that you can remove some of those areas of uncertainty, and perhaps get better consensus around the presentation aspect of it. Because I agree, I think that oral assessments are harder than written assessments, sorry, in terms of the process, but you're actually assessing something different.
Yes.
And I think maybe that needs to be reflected in a different scoring system.
Where they people end up with quite high scores, you can get with oral.
And that is probably part of that information.
Can I just ask, back to what we were talking about?
So I guess we're talking about what is accepted as close enough versus what is different, because you were saying that in one of the previous situations where you'd use this, a score of 18 was really hard. Whereas if you multiply out 3 by 1 by 4, you end up with a score of 12, which is quite high on a scale where 18 is high, but it's not a majorly difficult case. And so if 18 is too hard, where does that put 12? So I guess that's where I'm trying to get some concepts around what's the same and what's different. This is what's useful. There's lots of conversations. This is what we, and this is, I think what we've found is that the conversation that's the most important part of this. It's not the actual scoring.
It's a sharing of and I'm enjoying talking to each other through the microphone.
I'm very aware that Deborah's supposed to start to talk now.
And Deb's going to start, so I'm really enjoying this.
So do you want to see talk to this? I'll try to follow your own.
Do you want to?
It's fine.
It's allowed.
So Joy, a 23-year-old woman, comes into the pharmacy and asks for something for her runny nose, which has been worse in the past week. Also, since the wattle has started flowering. She has taken nothing to treat the problems so far, and is taking no other medicines. She has no preferred therapy. The question is, what would you do? What would you recommend for her and why? And this is an oral assessment. So we scored this as 3, 2, 3.
You went top nuts.
2, 1, 2.
2, 1, 2.
Yeah, we went into.
Didn't you want the justification? Isn't that another level?
Well, that was what we and we did toss up between 2 and 3. But we thought it was a simple case of allergic rhinitis. It's reasonably strongly protocol driven that you go for an inhaled corticosteroid. There were no comorbidities that required any justification or application beyond that. So we thought that if you were pushing towards 3, there might be a reason to not go for the first line therapy. So we kind of went, this is just remembering a treatment algorithm for allergic rhinitis. You need to recognize it's allergic rhinitis. There's nothing there that suggests it's not allergic rhinitis. So we went with 2 there, but we did sort of toy between 2 and 3 as to whether it was a apply or evaluate, analyze.
I guess in terms of the diagnosis of allergic rhinitis, though, given that like that differential can actually be quite difficult, I think, for a student, depending on the questions that they ask, both open-ended and closed-ended, and just ruling out red flags. So potentially, like, although
Flowering what will not give it away.
I guess
Some
probably
people, yeah,
could interpret that as a trick. Like, I don't know.
yeah.
I think that's what you said there, that
Yeah.
students might be thrown off by that. And I guess with the, I don't know, the added complexity of COVID now.
Yeah, I was gonna say, what if they go down the track of COVID?
So that's, I think, why we
Well,
can.
what
offer
just
for-
made it worse?
I'll give you that one.
I think we have to recognize that the people are going through clinical reasoning.
Yeah.
So the steps of clinical reasoning will include history taking, data collection, fact collection, and then processing. And figuring out which one actually is the priority, I guess. And any one of those are valid. If they ask the right questions, they might go down COVID on their own.
I think we, in our cases around coughs and colds, have been very clear to shut down the COVID line of thinking. And I mean, we didn't give all the information in the case. And if we were actually thinking out a proper case, proper scripted responses, we shut the COVID line down. I've done a rat test this morning and it's negative. So we weren't.
Well, that
thinking
wasn't
down
in
that
that
line.
scenario.
I know, we didn't give you all the information you
I'm
needed,
saying
Betty.
my scenario.
I'm sorry.
Sorry.
I'm going to take myself away from the mic now so I don't get into further trouble.
I was yelling at you.
Okay, so, yeah, we just.
Oh, yeah, suggestions. Yeah.
Oh,
Thank you. Yeah.
So just to wrap up, we can use case studies to access the ability of students to apply knowledge. And this tool is a way of assessing and ranking cases, and just to acknowledge Dan Malone, Chris here, anything and Chris.
We enjoyed it. Conversation via. Enjoy it. Next time, get people talking. Next time, I'll be lost. Yes. You are not gonna. That happened in 75. Trying to be so screwed. I just.